Victoria and I are going to be discussing de-escalation of an acute suicidal crisis with patients that we serve. So as mentioned, my name is Maritza Lorenzana, and I'm a clinical social worker here at the Boise VA. I've been here since 2013. Before suicide prevention, I did medical social work, and it's been 2 years that I've been on the suicide prevention team. I think a lot of you all might agree suicide prevention can be a very taxing role. But some of the things I love about this job is my collaboration with a lot of VA providers, helping veterans and their families, and of course, a lot of the community partnerships that I'm able to participate in.
And my name is Victoria Thompson. I currently work also at the VA as a suicide prevention specialist. I've only been here about 1.5 years, but I love helping veterans and families through their emotional crises. Prior to this, I also worked in medical social work at St. Luke's. I actually recognize some of the people on the panel. And I maintain my own private practice in Boise, and I've served as adjunct faculty at Boise State.
We also want to give a shout out to Travis. He's on the call as well. He's our community engagement and partnership coordinator, and he's been really vital in connecting us with ECHO so that we're able to complete this presentation. So just a couple disclosures. Victoria, myself, Travis, none of us are being financially compensated for this presentation. A lot of the materials in this presentation are not views of the VA or the government. It's information that we have gathered through our own lived experiences as clinical social workers, and Victoria and her private practice that relate to suicide prevention. Of course, a lot of the tools that we have are because of the VA and the resources that were offered here through our employment and the research. So we also want to say, that we might use veterans a lot through our presentation today. Well, we're really trying to say client so that it's more general and specific to all of the providers who are listening to this presentation. But occasionally it might slip out that we say veterans, and what we really mean is just general clients. So learning objectives is identifying who's at risk, how to recognize a suicidal crisis. We'll talk about some tools on how to determine that, and also ask what tools you all are using out in the community. Identify key factors to determining acuity. We'll discuss lethal means safety and understanding the steps for effective de-escalation. So this first graph, it has a lot of information, but this came out from National VA, and it discusses suicide rates. This is specific to veterans, so the veteran population, but it's an important graph that gives a lot of, it's a one-page document that gives out a lot of just information on where we are today and comparison maybe to a couple years back. We're able to see down here in this veteran suicides per day. We're able to see, some anchors of hope that suicide rates are decreasing, have slowly decreased from 2018 to 2020. I was surprised by the 2020 data just because we were in the midst of COVID and a lot of isolation, and a lot less just that human connections. But the rates are, they have gone down. Some other things to notice is for the unadjusted veteran suicide rates by race, we can see that white veterans, and we know this is also not just for veterans, but the general population, non-veterans, white folks tend to also die by suicide at higher rates. And we know that it's males. So on this one, we could even see non-veteran males are die by suicide at a higher rate than than veteran females or non-veteran females. So going with that, we can also see the age ranges. 18 to 34 is significantly higher, and then it kind of goes down, and then there's a spike again with individuals who are 75 and older. And lastly, in this middle box, we can see that the majority of death by suicides are by firearm. So 71% for veterans, and we know that the majority for the for non-veterans, the highest method is also by firearms. So we will discuss lethal means counseling and safety planning around lethal means, primarily firearms, later on in this presentation. So we ask ourselves, why are white men more at risk potentially than other folks in our community? Some things, that moved by itself. Some things to consider are cultural differences when we're working with the populations that we're working with. Specifically, if you are working with white males, we know that there tends to be a lot of specifically with the veteran population that we work with, there's still a big mentality sometimes that folks have about, lifting myself up by my bootstraps, not talking about my emotions, sometimes being the head of the household, not reaching out for help. Those could be a lot of cultural things to think about when we're assessing for risk. And not just for white men, but we know because white men have higher suicide deaths, it's something to consider. Something that a lot of us, even sometimes I as a clinician, don't consider our religious affiliations. In Mexico, a lot of folks are Catholic, and their suicide rates are a lot lower. And so trying to connect with the clients that we work with, seeing what their spirituality is, and how do we build collaborations with religious leaders in our community to also provide support, specifically if you're working with rural clients that are in rural communities. Speaking of rural communities, data shows that white older males who live in rural environments, who are low socioeconomic status, also are higher risk. And if you're in a rural community, sometimes you don't even know what services are available in regards to mental health and also medical care. And we know that we've seen something good that happened with COVID, I think, is virtual encounters. A lot, even the VA has taken a step more towards being able to help some of our rural veterans and clients by doing virtual appointments, which we've been able to do more outreach. So things to consider, in your agency, are you able to do that? And is that, encouraged? And then just, as I mentioned, just emotional literacy and how to express feelings, specifically if you're a white older male, and the difficulties that come with that. We know with this younger population that's at higher risk that we saw in the chart, we think about purpose for living. What is our purpose? With the veteran population, when veterans discharge from their service, that purpose kind of disappears, and now they're in civilian life and they have to figure out what their new purpose is. And that can be very overwhelming for a lot of folks. With the older population, we think about retirement, and we think sometimes about divorce that might happen later in life after specifically children have left the home, and that purpose kind of gets taken away, and it's trying to figure out what our new purpose is. And whether you're young or older, that could be very overwhelming, and how to share those emotions and seek help and guidance. It can be very difficult. Okay. So we also know chronically ill individuals or somebody who has a change in medical functioning, their ability to ambulate, ability to drive, possibly, some family members or friends saying you can't drive anymore. That change can be that it's very difficult. We know impulsivity issues, anybody experiencing substance misuse. If somebody's intoxicated or under the influence, they could be at times a lot more impulsive and participate in risky behaviors. And of course, anyone who's experiencing intimate partner violence at home are also at higher risks. LGBTQIA plus community, we know even with veterans, higher risk suicide rates are also significantly higher. For a long time, the military had don't ask, don't tell. And so a lot of veterans didn't seek help because of that. So now we have an LGBTQI plus A plus coordinator here at the VA. We were at Boise Pride, and we're here to serve everybody who served. So what's the message in your clinic, your agency, to let the clients that you serve, letting them know that you're there regardless? And we also know those experiencing homelessness also have higher rates of not just risk, but also suicide deaths. Not having a place to stay, a safe place to stay, is also very isolating, and you could feel very hopeless, especially because there isn't a quick fix with housing resources in our community. So what tools do we use here at the VA? I'll go over those, but also in the chat, feel free to type out what tools you use at your agency, because that might be helpful for other folks in this presentation, and even to us as presenters to see what standard of care is out in the community. So here at the Boise VA, we have a national initiative, Risk ID, which is a standardized process for assessing for suicide risk for all veterans. So every veteran receiving care at the VA, medical or mental health, is assessed for suicide risk at least once a year, unless clinically indicated to assess more often. So as mentioned, every veteran once a year, and the screening method that we use here is the Columbia Suicide Severity Rating Scale, so the CSSRS. And so every veteran that's receiving care, we're working hard to make sure they are assessed for suicide risk. In the event that the veteran answers yes to some of the Columbia screening questions, the next step that we do with screening is completing a comprehensive suicide risk evaluation, which goes a lot more in depth into, what is their plan? Do they have intent to follow through with this plan? What are some protective factors, risk factors, past self-directed violence or suicide attempts? And also it gives clinicians a little bit of guidance on what are the next steps to take as far as safety planning, or possibly recommending an inpatient hospital stay. So let's see, did folks in the chat box, I'm just looking over real quick. I could see the CSSRS, the safety planning. So it looks like a lot of folks are using, the PHQ-9 can also be, yep, it's a prompt for further screening. CSSR for youth, yep. So a lot of great, yep. All right.
Okay, now we're going to talk about the typical signs and symptoms, and feel free to add in the chat what you think those might be, and we're going to go over those. The next slide. So, yeah. and we'll go back to that in a sec. So other things to, you can see the different signs and symptoms here. And I think, a lot of them are pretty predictable and logical. One I want to point out is change to baseline behavior. So a lot of times, for example, here at the VA, when we are assessing for suicidality, we know the veterans pretty well. And if we're seeing something that's pretty different, unique and new, and in some cases, that can be elation or happiness because they've decided on a solution to their problem and that is ending their life. So sometimes you'll see a sense of happiness and relief. So that's just something to keep in mind. So I know this looks kind of kooky that we have a cat in our presentation. This is my cat named Echo, coincidentally. I'm bringing her into the discussion because I think she provides a good metaphor for how to deal with acutely suicide patients. So recently I had to take Echo to the vet for a hurt leg, and knowing that she was hurt and knowing how anxious she gets when I close all the doors and get out the cat carrier, I had to be careful how to approach her, right? To get her safely into the carrier without further injuring herself or me. So in theory, this is the same issue that you have to deal with when you're dealing with an acutely suicidal client. How do you get them the help that they need without injuring them or yourself further? So to do that, it's really important to understand what's happening in the brain during a suicidal crisis. So let's look at the neurology of a person in trauma. The limbic system, sympathetic nervous system, is on high alert. It will activate the fear response, and the limbic system will simply turn off the power to the cerebral cortex. In other words, that poor amygdala down at the bottom, the little green guy, is on overdrive. The flight, fright, freeze, and fawn reactions of the amygdala are ready and raring to go. And we know that the client in crisis will suffer a steep drop in inductive, deductive, abstract, and even logical thinking. The client may sweat more, their heart rate is faster, they can suffer a temporary hearing loss, and even literal tunnel vision. The hormones, chemicals, blood flow, and electrical signals that the client has are flooding their limbic system with the goal of resolving the immediate crisis. They are quite literally not in their right mind. So I want you to think about what you think can happen when a client's sympathetic nervous system is in this state, and what happens if you don't handle it properly. And you can put your answers in the chat if you would like. Right, so now we're going to get into the steps. So at the VA, most of our interventions take place on the phone as a result of follow-ups to the crisis line. As Maritza mentioned, telehealth is wonderful, but it can also present other challenges. So often, due to telehealth, we can't tell where the client is located, if they're alone or if they're with others, and what general environment they are calling us from. So first and foremost, it's essential that we determine the location of the caller. And when we intercede in person, it's also critical to know what means the subject has to hurt themselves or others within their current environment. So important to remember that very innocuous things like you see listed here can be used to thwart a needed intervention or to inflict self-directed violence. In a hospital setting, cords, for example, from medical equipment, can be used for self-strangulation or hanging. So step 2, further remembering poor Echo that needs to go to the vet. I don't want to injure her leg further, so I'm queued up to create a safe space for her while containing her ability to escape. And you'll want to do the same thing for your client in crisis. So specifically, you're going to want to be aware of exits if you're with them physically. It would be helpful, and most of you have this, to have a phone nearby so that you can use it to dial security or police if needed. You'll want to be aware of the possible exits the client may use and that you may have to use if the client turns violent. Technologies like this are very useful in the clinical setting, and they allow us to de-escalate and remain engaged while seeking support and help, because we want to keep our eyes on the client. This is really important. You're going to want to manage your own anxiety. And that can be tough when you're in a crisis situation because your brain is also going a million miles an hour. So in person, that means slow, unthreatening movements, maintaining eye contact. On the phone, that means using an even tone, all those great communication skills, listening and acknowledging, checking, understanding, and remaining calm and non-judgmental. And if you want to share in the chat the techniques that you use to ground yourself in the midst of an acute crisis, that could be helpful to others. Okay. So where are we? Oh, a little bit more back on to, sorry, I really want to talk about empathy not being sympathy. It's not useful. It's disempowering, and really try to help the client move out of their negative, concrete frame, speak to their strengths, speak at their resiliency and their ability to recover. And again, just keep remembering the limitations of the brain. So use clear language, concise, short to the point, be directive. Tell them specifically what you want to do, whether it's taking a sip of water or unloading their gun magazine. Okay. And I just sort of talked about some of these. So creating connection and trust. We ask the client to define the problem because we're trying to achieve that sense that they have agency and they have control and they know what is wrong. This gives us the opportunity to listen, to validate, to ask more open-ended questions so that we can buy some time. And you're going to hear from Maritza a little bit later why that's important. And again, expressing that empathy and positive regard, speaking slowly, softly, using those succinct phrases. So step 4 is solidifying the therapeutic alliance. This is such a critical skill, and I think it's actually quite easy. Basically, you want to move out of the role as provider and authority and instead speak to the client human being to human being and try to tend to their basic needs. You know, if you see that they're cold, give them a blanket. If you suspect they're thirsty, give them a drink. Give them a chair to sit in. Just pay attention to their physical presentation. What is so important about this is it can help move the client from that amygdala charged state to the whole brain state. And Maritza has a great story about how she utilized this.
So a few years back, I was covering in the emergency department here at the VA, and a veteran was brought in by a concerned citizen that was hiking up in the foothills. It was summer, really hot, and he looked disoriented. So they brought him to the emergency department at the VA. When he came in, he denied suicidality, but he was agitated. He didn't look good. He looked like he was under a lot of stress, and he didn't want to talk to anybody, and he left the emergency department, but he didn't get far. He sat down in a bench outside of our emergency department. And so I saw kind of what was going on, and I spoke with our VA police, and I said, you know, I'll go try to talk to him. And I went out there. He did not want to talk to me as much as I tried. So I said, fine, I'm going to go inside. But before I went inside, it was hot. He was found in the foothills. I asked if he wanted some water. And he, like, that question just kind of caught him off guard. And he was like, yeah, wow, I didn't even realize that I'm so thirsty. So I went and got him water, and when I came back, he was such a different person. He was able to hydrate, and I was able to validate his concerns, and we had a very in-depth conversation about what was going on, and I was able to connect him with some resources so that he could come back to the VA.
Great. Okay, now we're going to talk about helping the client examine alternatives. So as we discussed, the brain and trauma with a shutdown cerebral cortex sometimes can get very concrete, very black and white. They're going to have a hard time, right, coming up with alternatives to their plan. So it's really important for you to talk about what might be some alternatives to what they're considering. Here are some great questions that you might pose to the client in trouble. Some of this is some solution-focused therapy you may recognize. You could even ask the miracle question if you'd like. And then we also complete a safety plan that explores these alternatives in a collaborative manner. And that is super important, that it is collaborative. We want to elicit their needs and potential solutions. Before we go on, I just have a few more things. So I do want to remind you that asking a patient about their suicidal thoughts will not encourage suicidal behavior, and you do need to ask that question and get clarity around their plan, their means, etc. We know in the emergency rooms, no harm contracts have proven to be ineffective. So the current standard, again, is doing safety planning. So when we can speak to veterans and complete a safety plan, we provide specific names, or we ask them to provide specific names and numbers that they can utilize when they're in a crisis. We suggest they keep that handy, tape it to a mirror, keep it on their bedside table, put it on their refrigerator, because they're not going to be able to think of these things. So it needs to be really accessible. So those who are referred to our psychiatric unit, we arrange follow-up with mental health providers. I also want to say that we flag people that we consider to be high risk for suicide, and we educate them that if they don't follow up, we might initiate a welfare check. So it's just really important for them to be aware of that. And, you know, why is collaboration so key? Because it sends a message that the client matters, that they have personhood, they have the right to be treated with dignity and respect. And it sends the message that they have the capacity to self-regulate and manage their issues. And more on making plans. I really want to point out that a lot of our veterans are, they have problems, they have PTSD, they have problems with institutions and with the VA and oftentimes with the police. So it's really important to be aware of that if you're a provider. A lot of providers, unfortunately, have a kind of a cynical view about suicidality, you know, the feeling that they can't do much to prevent it, but that's not true. So you should really examine your biases and, again, do the techniques that we talked about, grounding yourself, using the correct language, adjusting your mood. It's really important to do this so that folks who are suffering a mental health crisis will continue to use the hospital and other resources in the community to help them. A key part here, of course, is making sure that they are a part of it and making sure that those plans are realistic and not overwhelming. And you can even ask them, how likely is it that you're going to do this? How likely is it that you're going, and you can use a scale if you want, talk about barriers, really get a sense and really engage them in the planning and make sure that they feel a part of that process.
So after completing a safety plan, sometimes, we might forget to go a step further and talk about lethal means safety. Specifically, when clients return home and maybe they still have access to medications, they have access to firearms. What does that look like? And do we as providers feel comfortable discussing lethal means safety? So hopefully, we're able to give you some tools and ideas on how to have that conversation with the clients that you serve. So lethal means safety is discussing safe storage of lethal means and also trying to create time and space. Creating time and space between somebody who's experiencing a suicidal crisis, thinking that they want to end their life, even creating 10 minutes between that impulse to reach for their firearm and having difficulty taking the gun lock off, or having difficulty accessing their medications or other plans that they have had, can save your client's life. So we want to create that time and space between that suicidal impulse and the ability to actually harm oneself. So that's safety means restriction. It needs to be, as mentioned, even just like with a safety plan, it needs to be very collaborative and veteran centered. And another thing to also acknowledge is, specifically in Idaho or the Northwest, wherever you're meeting, you're here with us from, we have a lot of clients who are in rural areas who have access and own many firearms. A lot of the veterans that we serve, they tell us that the Second Amendment is part of their identity, and them being able to carry a firearm is part of their identity. So how do we talk about safety planning around firearms when our clients might say that that's part of my identity? And that's why it's very important to really be realistic and veteran or client centered. So some things to consider are having family be part of this conversation of how to store firearms, medications, any other form of lethal means. Maybe having the ammunition removed from the firearm so it's not loaded at all times. That could also include changing the safe combination. It could include, if they don't want to remove the firearms from their home, maybe they could have an individual gun lock on each firearm, and the keys to that can be in a completely different location. Maybe a buddy holds on to the firearms and they're only used with when they go hunting, or there's another safe person around. With medications, if there's a caregiver in the home, a spouse, even a roommate that could help with accessing those medications, or only having like a medi set with what's needed. If you're a prescribing provider and you know that your client struggles with suicidality, maybe you're prescribing less medications at a time. If it's a client that's been maybe hospitalized or changed different medications quite a bit, having that conversation of, hey, where are you storing all of your unused medications that are discontinued and you don't need to take anymore, and providing education on disposing of those medications at maybe like a community drop box. I know those happen around Boise and our surrounding area pretty frequently. So having conversations like that, having family members involved, and sometimes even breaking down the barriers and misconceptions that our clients might have, that if I say I'm experiencing thoughts of suicide, that somebody's gonna take my firearm away, and that is not correct. Even here in Idaho, somebody could have a felony and they can still own a firearm. We VA providers, that's something that we do a lot. We don't want to take firearms away. We don't have a place to store them, and they are valuable. So the police department can't hold on to these firearms for very long unless they're evidence. So just thinking about those different conversations to get that buy-in from the client that you work on how to store those any lethal means. From this graph here, we can see that that suicidal crises, that most of the time, even 5 to 20 minutes, 48% of folks, they're not going to be suicidal, and they're going to not be impulsive anymore. But even 71%, that suicidal crises, like impulse period, 71% of veterans kind of are able to seek help or not follow through with their plan. And we can see in the little pyramids that 85 to 90% of firearm injuries are fatal. And even if you survive, if we have a client that survives a firearm injury, there's a lot of medical limitations that come with that. Sometimes they could be lifelong. All other methods combined, still 5% are fatal. So we are very, we focus a lot on firearm safety just because Idaho, that's the leading cause of or method within suicide deaths in our area, in our state. So, yeah. So we know that lethal means safety works. We want to have these conversations when our client is not in crises. We want to be proactive with these conversations. About 90% of people who survive a suicide attempt do not go on to die by suicide. This is a sliver of hope for me, specifically when, we work with, Victoria and I work with a lot of individuals who have attempted suicide before, but being able to discuss the safety plan and update it as needed, continuing the lethal means counseling and conversation ahead of time can really save someone's life. So it's very important. Another thing that we're doing here at the VA is we're continuing to find access for veterans to seek care. We know that that there's a lot of financial barriers sometimes with seeking care. So a service, a new initiative, a new policy that we have is that if a veteran is in crises, in suicidal crises, we encourage veterans. So if you know of a veteran, you're working with a veteran, maybe they're not connected with the VA, but if they're in a suicidal crisis, we want them to access care. They can come to the VA, they could go to community hospital, and they can receive, under Compact Act, they could receive care without being worried that they're going to have a huge financial burden when they discharge. So under Compact Act, veterans may be eligible for 90 days of inpatient care and up to 90 days of outpatient mental health care or medical care that's associated with that suicidal crisis. So if we had a veteran that possibly attempted by cutting, that any wound care, antibiotics, those are medical care that would be covered under that. So, and we can send out more information on the Compact Act to anybody who's interested. We can either coordinate with ECHO or you could reach out to us here at the Boise VA to share information on the Compact Act. So this is one way that the VA is trying just to encourage veterans to seek mental health care. And we just covered a lot, but we wanted there to be room for questions, and maybe we could provide answers.
And we made time.
Yes.
Shannon, so we're proud of ourselves.
Timing. That's
I've
great.
I've been looking at the chat, and I love everybody's what people have been typing in, the different questions that we've asked about the different screening tools, how to keep ourselves as providers grounded so that we are able to be with our client if they are having a suicidal crisis. So yeah, but we're open to questions.
Great. You guys can go ahead and stop your share and then we'll all come back together. We did have a few questions in the chat that I'll start off with and then we'll open it up. So Connie Powers said, Do you use the emergency risk assessment order with clients?
I'm sorry, can you ask that again?
Yes. Do you use the emergency risk assessment order with clients?
No,
I haven't heard of that.
no, we haven't heard of that. It's not something we use at the VA.
Okay. And then Amy Newsom said it would be helpful to hear more real life examples / stories of the very initial interactions, like when Maritza said offering water that helped clients get out of their limbic override states. So I don't know if you guys have any, or if our audience has any that they want to chime in with that.
I can share, well, I was on the crisis line with a veteran who was driving a big rig. It kind of gives me pause when I go down the highway now, and they were experiencing a panic attack and feeling suicidal. So they contacted the crisis line. Kind of, again, back to those simple things. He had a picture of his family in his glove compartment. I asked him to reach over and to get that and look at that. I suggested, again, that there's a big correlation between dehydration and panic attacks. So if he had some water, to take some small sips. And he had some nuts, again, some good little protein snacks, kind of helped calm his body down. Fortunately, he was able to get to the emergency room safely, and we did arrange follow-up treatment for him. So that was another example of things that you can do.
That's great. I don't know if any of our panelists have any examples of things they've used before with any of their clients. I see Ashley Hammond, who works with the Boise Library, said, I keep cold water bottles in my office at the library. They're a great tool to open with someone who may be heat exhausted and lead to a more conversation and rapport building. It's good.
I mean, I think these are things that are really simple. I think one of the easiest things that we can do as providers is kind of overthink it, right? And like over treat in that moment. The goal is to just kind of bring it down. You know, we can use some of those mirror neurons to help sometimes folks with just regulating ourselves, speaking really softly, you know, having that kind of warm and inviting language and body language and things like that. And I think when I've been in that situation in an outpatient setting, everything stops, right? We're not doing this like really hardcore evidence-based stuff, you know what I mean? We're not doing this like, we're stopping CBT, we're stopping all of this stuff. I mean, the really specific stuff. And I'm just being a person in there with someone, hearing someone and letting them talk about it. And my willingness, I think, to, and all of our willingness to have that discussion is super helpful, because many people that are in crisis like that fear discussing it. They fear talking about it with their family members. They don't want to talk about it. They may want to talk about it and process it, but they don't want to share that out of fear of judgment, fear of people's reactions, fear of being locked up, you know, all of those things. So I think if you can just bring it all down and just sit in a space with someone and allow them to kind of have the feelings that they're feeling and not overreact in your own right. I mean, it can change the tide.
Another thing to think about also is if you are doing virtual appointments, or if you're on the phone with somebody, obviously it's hard to, you know, do some of these physical things that you could do with somebody in the emergency department or that's in your office. So sometimes even just, this is helpful for myself when we want to slow down, and asking if they're willing to do maybe some breathing exercises with you. And just asking them, you know, like, okay, let's center ourselves. Let's do 1 or 2 mindful kind of activities to calm down, to get our anxiety level a little bit lower. And it's helpful for me as a provider to also slow down, because as mentioned, like, you could overthink it, and that transference could come to that client that you're with, and just they could feel overwhelmed as well.
I've got a few other suggestions from audience members. Jeremy said ice cubes in your hand as a sensory grounding activity. Deanna Thomas said that she always offers food in the emergency department with her patients. Margot Reed said that she uses the animal alphabet and 5 senses grounding has worked. Travis said having a box with sensory materials such as photos, favorite snacks, music, etc., has been a useful tool that he's encouraged. And then also just saying, you know, this is what's worked for me, what's worked for you in the past, and all of that.
Absolutely. Yeah. Get that
Awesome.
engagement. Yeah.
Let's open it up to other questions from our audience. What do we have? Sometimes we've got a little wait time while people write their questions into the chat. Anything from our panelists, thoughts, questions, ideas that this has sparked for you? Go ahead, Tara.
This is Tara Whitaker, family doctor. So thank you for your talk. We're pretty lucky here at the clinic. We have a couple of social workers, and I was just talking to one of my colleagues because I knew we were having this talk about how helpful it's been to have a process, because I think it's just can be such an overwhelming thing, especially in primary care, to have that crisis kind of hit you. And so we're really lucky to have social workers here and have brought a lot of like energy to that over the last couple of years. But I think and we're doing the universal screening with the Columbia screen, so I think that's also been interesting to see how many of those actually flag even for mild symptoms, like they're not acutely suicidal in that moment. But I think it has brought up, like, I think it comes up a lot more because we're asking. And I think I think I've been caught off guard by some patients. I know they have chronic issues, but I think it's been such a good reminder to actually ask and make sure that we're screening people who wouldn't necessarily come to light. And so I think knowing, asking patients even when we're it's not even a depression diagnosis, because I think that's one of the things that whenever they hit care, whether it's you're a nurse or you're a physician. And I know when I first started training, it was a little uncomfortable to ask, but I think patients have gotten really used to it because we're asking in a lot of other settings. But also, I think sometimes if you catch somebody and they're willing to give you that information, it can be so life changing. And then knowing what you're going to do. So this was so helpful, because I think knowing what you're going to do in that moment, because once you ask and you have the information, you have to do something or at least have to be there for them and figure out what they need. And I think that's definitely how I approach it. I guess one of the things I'd be curious about from the speakers is, or anyone, is like, are there times when it hasn't gone well? And I guess I'll share, like, I think there've been times when the patient did it like escalate, or, you know, a patient refused to go to the next level, like the next, higher level of care. So any thoughts on times it hasn't gone well that maybe we could learn from? I don't know if anyone has something to share.
Well, I think we run into a lot of resistance when we're on the phone with people, and we can tell they're in an acute crisis. The safety plan isn't working, our slow, soft, gentle voice and other plans aren't working. That's when typically we'll initiate a welfare check. But the key, of course, is that we want to know what weapons are in the home, what they might be using, because whoever shows up is going to want to know that. And we want to stay on the line with them. We want to keep them engaged. We want to do what's called the warm handoff. Because there will be times where no matter what you do, they're not gonna calm down. Yeah.
And I think that'd be great too, depending on where you work and your agency. Like, do you have a policy in place, or do you have help that can help you with that? Because if you need to stay on the line, the telephone with a patient, and you also need to initiate a welfare check, who can help you? Who's a coworker that you could send a message to? Whatever your communication is at your agency to help you with that, and also to feel comfortable and confident in calling whether it's Canyon County Dispatch, whatever dispatch, or even just 911 to get help out there. Sometimes that could be intimidating the first time you do it. And we've had to do a lot of those. And as much as possible, I tell the clients that when I do that I'm really concerned about them, that I'm calling for a welfare check, and sometimes they get really upset with me and they hang up, and I'll still try to reach them. But sometimes they stay on the phone with me. Actually, I'm surprised by it, but they'll stay on the phone with me, and then I could hear when there's the knocking on the door, and then we're able to like safely disconnect. But there's definitely some resistance, and that's, if they're an emergency department, sometimes you have to place a hold. And in the moment, they're going to be angry, they're going to be upset. But we want them to be safe.
And by that time, for the crisis to de-escalate and get that whole brain coming online again. Did that answer your question, or?
Yeah. No, that's great. I think it's super helpful. And I think when you're in an outpatient setting, I think that's what's, when we were in the hospital or when I was working in the ER, it's so easy to just put them on a hold. But I think sometimes in the clinic, like we've had people run out of the clinic, or, had people like, and I've had, I have a patient, I called a welfare check, and she's still so mad at me for sending the police to her house. Though I did learn that what should happen is it shouldn't necessarily be like a uniformed police officer as the first person, like they're the backup, but like that they have people, at least here in Ada County, that'll go, that are much more the mental health team. And I was so relieved to hear that. So I'm not sure what actually showed up at her house. And again, when you're in that state, you're not thinking super clearly. And so, yeah, anyway, I think it can be a tricky one and then when I'm trying to maintain my rapport that I've built over years, but also do the right thing. And I think it's just going to be a case by case, I think.
It is. And, if they really don't want that welfare check, I use that as motivation. Okay, well, what's our safety plan? Let's go back to those. Let's figure out let's hold some ice cubes, right? Let's listen to some music that can help motivate them. Right.
No, that makes sense.
We only have, sorry.
No, you're fine. I just wanted to, sometimes as a clinician, and I worked at the suicide hotline for a while, so I think sometimes recognizing safety measures that aren't necessarily what we would automatically think of. And for one example, I had a client who, the way I was able to keep him safe, the way he agreed to stay safe, was so that he could get off the phone and call a lawyer to kick his kids out of his house. But it took us like 45 minutes to calm him down so that he could, because that was one of the big stressors, was that his kids were living with him and he didn't appreciate that. And I would never have thought about encouraging him to like call an eviction lawyer, but that was ultimately what did it. So I think, really listening and having the creativity when it comes to finding those safety measures and finding those plans is important to remember as well.
Yeah, and that kind of goes back to you remaining calm, right? De-escalating your sense of urgency, because you can help them come up with those alternatives. So it's one and the same, because it's going to be hard for them in the midst of a crisis to think of any other option. Yeah, that's great.
Maritza and Victoria, thank you so much for giving this presentation. This was truly great. And I don't know if you saw, but we had over 120 people on this call. So it was definitely a hot topic for this crowd. So we hope to have similar topics like this. So thank you very much. We want to invite you all to come back in 2 weeks on October 4th, when we will have Dr. Nicole Fox, who is the clinical assistant professor at UW School of Medicine and an associate system medical director at St. Luke's Health System. And she will be presenting on borderline personality disorder. So we hope that you will all come back for that topic, and we will see you in a few weeks.